Let's now consider the other option in the trial, active monitoring plus metastasectomy, which is surgery. Depending on the position of the nodules, there are two ways of doing this. A keyhole and camera technique called VATS, which stands for Video Assisted Thoracic Surgery, or a thoracotomy, which is through a cut made between the ribs. If both lungs have nodules and the surgeon recommends removing them in one operation, this can be done through the front of the chest in order to reach both lungs. After chest surgery, it's usual to leave a small tube coming out through your side for a few days so that any leak of air or fluid can escape. Professor Tom Treasure, a thoracic surgeon, will now explain the different types of surgery in a little more detail.
So first of all, I'm going to explain the two different approaches. That's how the operation is done from the outside. Now we always have the patient on the operating table on their side. So that's the patient there. If we do it by the VATS approach, that's keyhole and camera, we only need 3 quite small incisions, 1 to 2 centimetres each. And usually through the central one, we put a telescope which is connected to a camera at the outside here and off to a television screen. So the surgeon watches the whole of the operation on the screen, inserts various instruments and tools, and so that's what it's like from the outside. Now, if the operation is to be done by a thoracotomy, that's a full-size cut in the side of the chest. The patient's on the table, very much the same position, but the incision is here in the side, and that's called a thoracotomy, and that needs to be big enough for the surgeon's hand to go in, so it's quite a different approach. Now let's look at the operation on the inside. So the surgeon can see the lung either on his camera or directly in front of him. If there's a nodule near the edge, like that, we can take our staplers, which also have cutting blades within them, and go across there and take a wedge out. And the rest of the lung is left intact, so very little lung lost. And that certainly can be done with a keyhole approach. Now there are times when you can't use just wedging like that. And that might be if the nodule is much closer in, say in there, and in through here come all the great big blood vessels and everything. Now, just taking a stapler and wedging that out would be dangerous. So this is the sort of circumstance when the surgeon would want a full thoracotomy and have full control of the lung and might well have to take out half of the lung. Now the lung comes in segments, a bit like the segments of an orange. It's all one orange, but you have bits of it where it can be divided, and then you would lose half a lung. So this is a much bigger operation and has to be done in many cases through a full thoracotomy, even though the nodule itself may not be very big.
Now let's watch Professor Tom Treasure answering some questions that Mr. Sinclair and his wife have about the surgery.
This is, tells us a little bit about the surgery, but not very much. And I mean, well, you had a question on the extent of it, really.
Yes, really, because apparently these 2 lesions are very small. So I would have thought that you'd only be taking a little bit of the lung away because there's not that much to remove. And yet it says that there could be quite bad breathing problems as a result.
Yes.
So
Okay. Well, remember that the patient information sheet is written to cover a wide range of eventualities. Let's just look at yours, if that would be helpful. And this is the CT scan. Yeah. And with the CT scan, it's like a slice across. And you're looking at it as though it's from underneath, so that's your right lung. And this is where your heart is in the middle, and there's the airway just dividing to right and left. Well, there they are. So they're about that big. Now, you see how big the lung is, and that's just one slice that goes from top to bottom. If you just take those out with little margins or wedges like that, it will make hardly any impact on your lung volume.
Yes.
And that's your lung capacity. On the other hand, if somebody had a rather big one in here, and in order to safely remove it, they had to have a whole lobe of the lung removed, then you would lose more. I'll just draw that for you, what that means. You see, those ones are out there in your right lung. So there's a couple of things out there, and they might just come out with a little wedge of tissue like that.
Mm.
Now, another person might have something right in here, and in order to get rid of it, they might have to lose, say, half of the lung. And that would be a much bigger loss of lung tissue. Now, the other thing about it is that the approach can vary. So this is just the amount of lung you lose. But if we were able to go for those with keyhole surgery, which is 3 small incisions about that big.
That's my second question.
Okay. Well, shall we deal with this first? And this is to do with the lung capacity issue. In your case, it's not much, but for some people it could be a lot. But let me just complete this bit, because you see, also here you have to cut into lung tissue, and after you've done that, the lung can leak air. You have to have a tube in there, there can be fluid, so you can have complications even though you've lost a small bit of lung. So it isn't the long-term loss of total lung capacity, but what we hoped would be a 2-day stay for a keyhole operation could be a week or a 10-day stay. They're 2 different issues, but they're different between.
But in terms of my breathlessness, which is what, because at the moment I don't suffer from that.
Doesn't have any of that.
And we know your lung function is good, and there isn't a problem, and you're a fit man. So in terms of long-term lung disability, in your case, the risk is extremely small. So that doesn't quite apply to you.
You did.
All right,
you touched on my other question, Professor,
yes.
which is that it's clear here that there are these 2 possibilities. One is the keyhole, and the other is the thoracotomy. Thoracotomy. Now, my question is this: if I go into the PulMiCC trial,
Yes.
can I choose which of these methods I have?
Well, to a large extent, the factors that in general, the issues are technical, so that is amenable to the one and that isn't, and vice versa. But also, the surgeon may have other reasons to have a bigger look at the lung, that he's suspicious and wants to inspect it all, or that he's worried that there may be any other spread somewhere else, and he wants to have a full thoracotomy. So some surgeons, under certain circumstances, would give you a strong steer in one direction or the other. Quite honestly, if it just came down to a matter of your choice, who'd choose to have the big one, then they could have the small one. So indeed, I mean, that's in our minds too. So unless there was a strong reason to do with the technical access or something else, which the surgeon would explain to you, then it would be done that way. And indeed, if I were doing this operation for you, I would want to do it the keyhole approach without any question. And if you said to me, couldn't I have the big one, I'd think, why is he saying that? You know, I'd have to say to you, what's worrying you? What is the point behind that question? So it tends to go that way.
It might seem strange that your doctors are uncertain about the best course of action, but doctors do not have any good research evidence to show that as a group, patients having the surgery live for any longer than those who do not. Importantly, there's no information on patients' general well-being or their quality of life after metastasectomy. For example, you probably don't have any breathing problems right now, but occasionally surgery to remove some of the lung means that you can't take in as much air. So breathing can be more difficult, which might affect everyday activities. So the PulMiCC study examines the benefits and the possible harms of metastasectomy in patients with colorectal cancer that spread to the lung.